Hi, this is Dr. Gary Schwartz from Associated Eye Care, and I am going to do a quick presentation on ocular trauma. So the first thing to understand when you have a patient who has injury to the eye is, what was the nature of the injury? And I think this is similar to understanding trauma to any other part of the body. So with the eye, was it like a rubbing or a scraping type of injury, where like a tree branch brushed across the surface of their eye, or a fingernail? Was it a hard blow? Was it a punch to the eye? Was the eye hit with something sharp that could cut the eye either through the eye or just through the surface of the eye? Was the injury caused by something small like a pencil or a rubber dart? Or was it something big like a fist or a bottle or an airbag or something like that? Similar to other parts of the body, the eye is susceptible to abrasions and lacerations, contusions, and hemorrhages. But unlike other parts of the body, the eye can have special types of injuries like red blood cells in the front of the eye, hyphema, white blood cells in the front of the eye, iritis, retinal detachment, retinal tears, or globe rupture, which is a breach in the wall of the eye. We always look at the eye from the front to the back, so any of these parts of the eye can be injured from the front, the eyelids and the conjunctiva, all the way to the back, the optic nerves and the orbit and everything in between. So let's look at the eyelids first. So the eyelids can be susceptible to a contusion, which is just a bruising of the lids. The bruising can be so dramatic that it makes it hard to see or evaluate the eyeball behind it. And then there can be lacerations of the eyelid. So in this figure in the top, the laceration follows the orbicularis contours. It's pretty shallow, it's pretty superficial. This is a laceration that can be repaired much as you'd repair any other type of laceration anywhere in the body. This laceration here is deeper, it involves the lid margin. And this is obviously something that's going to have a more complex repair that would be in the hands of an ophthalmologist or even an oculoplastic specialist sometimes. This one here is interesting because it looks like it's the same location and orientation as this top one, but it has this kind of yellowish material that's emanating from it. So what's the difference? The difference is this one has fat that's prolapsing through it. And where's this fat coming from? Well, the eye is surrounded by fat above it, below it, next to it, and behind it, because fat is good padding. It protects the eye from hitting all this bony structure that otherwise makes up the walls of the orbit. Within the eyelids is this membrane, this layer that's called the orbital septum. And we can divide things behind the orbital septum, the orbit, from things in front of the orbital septum, the preseptal area. So if the laceration just involves the preseptal area, that was like that top picture, pretty superficial, can be fixed just by closing the skin. If the laceration cuts through the orbital septum, fat will prolapse forward, and that's an indication of a bigger injury because now all of a sudden the orbit is exposed. So this one here, skin only, it's preseptal, whereas this one here has orbital involvement, which means the septum has been breached. Bigger injury, bigger problem, bigger repair. Now let's talk about the conjunctiva. So one thing you'll get in the conjunctiva are foreign bodies, which is something that I'm talking about in another one of these quick lectures. Another type of conjunctival injury is a conjunctival laceration. And here we actually have a laceration in the conjunctiva. This is the cornea over here. So this is someone who probably got a fingernail injury or a tree branch injury. It's usually that type of injury. It's not a punch. It's more like a scrape or a cut. These heal well on their own. The way you diagnose these actually is fluorescein staining. So if you have a corneal abrasion, you're used to seeing that light up with fluorescein, but conjunctival abrasions will do the same thing. The treatment for this is just let it heal on its own. We usually put people on antibiotic drops or ointments to cover them while they're healing, but this will re-epithelialize on its own without need to do anything further. Now we go to the cornea, corneal abrasions. I'm sure you've had a lot of experience with corneal abrasions. Corneal foreign bodies, similar to corneal abrasions with a foreign body also. This is part of another lecture that I've done in this format. And then the last corneal type of injury is corneal laceration. So here we have the indication of the laceration. It's hard to see the laceration itself because corneal tissue by its very nature is transparent. So we have to look for other signs of the laceration. So what we have here is this brown blob, which is iris tissue that's been pushed out of the wound by intraocular pressure. And in being pushed out of the wound, what we find is that the pupil isn't round, it's tear-shaped. It's pointed in this angle here. And the adage that we use is the pupil points to the problem. The point of the pupil gives us the direction of where the injury is, where the breach is. This is obviously something that an eye doctor will have to repair in the operating room and try to push as much of that iris back into the eye as possible and close up the wound. The iris can be injured. The iris has a lot of blood vessels in it, and it tends to get injured by stretching from a blunt injury. If there's white blood cells floating around in the anterior chamber, we call that a traumatic iritis. A lot of us just make this diagnosis just by the history, but you really should see white blood cells floating in the anterior chamber in order to make the diagnosis properly, and that requires a slit lamp exam to do. The other type of iris injury is if instead of white blood cells there are red blood cells in the anterior chamber, then that's a hyphema. If there's enough red blood cells that you can see them grossly layered out like this, that's called a hyphema. If you can see red blood cells floating in the anterior chamber by using a slit lamp, but you don't see this layering of blood, then that's called a microhyphema. And these are just these just go away with rest. The bleeding itself isn't so much a problem as long as the pressure stays good. The bleeding is more of an indication of how bad the injury is. In the old days, this would be a week-long hospitalization with both eyes patched. Years ago, when we've shifted from inpatient medicine to outpatient medicine just in general, most of these patients have been managed at home. But they really, no school, if they're almost always kids, no school, no activities, just sit on the couch and watch TV for a week. Globe rupture is kind of the scleral version of the corneal laceration. It's usually seen with blunt trauma, though, rather than cutting like a corneal laceration. And here we have iris poking through this injury, which is just adjacent to the limbus, which is where the white part and the colored part meet. And again, we have the pupil points to the problem. Sometimes we'll have a patient referred to us where the referring doctor will say, oh, there's a foreign body on there I can't get, when what the foreign body is iris tissue. So globe rupture can look like this if it's near the limbus where the iris can peek out, or it could look like this. So here's a more posterior type of injury. This finding is called hemorrhagic chemosis, where chemosis means swelling of the conjunctiva and hemorrhagic means there's blood tied up in it too. This type of injury is almost always a globe rupture. Whenever in the emergency room it's felt that the patient has a breach in the wall of the eye, whether it's a corneal laceration or a ruptured globe, we do as little as possible in the emergency room setting. We don't poke, we don't prod, we don't try to spread the eyelids apart to get a better vision or anything. The worry is if there's a hole or a breach in the wall of the eye someplace, if we manipulate the eye too much, we can actually force things out of that hole, things like retina or lens or iris tissue. So we prefer to explore these in the operating room under a more controlled setting. So here are the takeaways from ocular trauma. One is get a good history. There's a big difference between blunt trauma and sharp trauma, scraping versus punching. So usually you can figure out the extent of the injury by what it was they got hit with and how it occurred. If the patient's very uncomfortable, it helps to put numbing drops in the eye for a few different reasons. One is if the discomfort gets better, then you know it's a surface issue, corneal abrasion type of thing. Whereas if the numbing drops don't help them feel better, then the problem is probably a deeper, like an iritis type of thing. Also, if they're uncomfortable and the numbing drops help them feel better, you got to do a better exam. Symptoms can lead you astray. History is better. So a lot of patients will have a lot of pain and poor vision with minimal injury. Likewise, some patients who have a pretty significant injury might have very little pain or might have reasonably good vision. So the history, the story, a lot of times is better than the patient's symptoms. Visual acuity and pupil can give you a lot more information. You know, if someone says, oh, I think I'm seeing pretty well, but their visual acuity is 2200, or someone says, oh, I can't see anything, and put numbing drops in their eye, and they say their visual acuity, and they measure their visual acuity at 2030, that gives you more information than just asking, how is your vision? So measuring vision and then looking at the pupil can give you a lot more information. If someone has pretty minor trauma, like they're in class and someone throws a pencil at them or a rubber dart, whether or not there's subconjunctival hemorrhage is kind of an indicator of whether or not they should be referred to an ophthalmologist. So if someone gets hit with a pencil in the eye in class and the eye is totally white and quiet, you're probably pretty safe not referring. But once there's subconjunctival hemorrhage there, it means the eye was directly involved in the injury to some level, and a referral is probably indicated. If you think the wall of the eye is breached, either there's a globe rupture or corneal laceration, stop fiddling with it, stop trying to get a better exam, just put a shield over it and refer. We'd rather you over-refer these patients than under-refer. And when in doubt, give us a call. Especially in the age of smartphones with cameras, and there's HIPAA-compliant programs on these phones, you can take a picture and share it with us, and we can talk about it over the phone. So if you can take a picture of the eye and show it to us, a lot of times we can decide what to do over the phone, which can help in the management of these patients. So thank you for your attention. Hopefully you found this helpful. Please feel free to contact me. My email address is below if you have any questions or if you have any suggestions for future talks of this sort. Thank you.